Liver cirrhosis. Let's study liver cirrhosis. Liver cirrhosis is an end-stage fibrosis of the liver, along with the disruption of its architecture. Liver cirrhosis is basically end-stage fibrosis of the liver. When the liver is in its end stage of fibrosis, along with the disruption of its architecture. Along with it, the architecture is also disrupted. Fibrosis plus abnormal architecture. So components are abnormal regeneration. Liver will try to regenerate. Second component is extensive fibrosis. Liver will have fibrosis. Both fibrosis and regeneration can be seen on biopsy only. That's why liver cirrhosis is technically a histopathological diagnosis. However, we do not always biopsy. Therefore, diagnosis in medicine for liver cirrhosis is done on basis of its complications. What are the complications of liver cirrhosis? Patients who have complication might come. First of all, the complications of the liver cirrhosis are responsible for the clinical features of liver cirrhosis. Patient will come with complications of liver cirrhosis. If a patient has abnormal regeneration or extensive fibrosis, the patient would be asymptomatic, but due to its complications only, the patient has some clinical features. And not every complication develops clinical features. Okay. Patients who have complication might come in a compensated state, or they might come to us in a decompensated state. Patients with complications may be decompensated or compensated. When do we say they have decompensated? When they have ascites, they have variceal bleed, or they have hepatic encephalopathy. Compensated means patient does not have clinical features. Patient is asymptomatic. Compensated. Decompensated means patient has clinical features. Compensated liver cirrhosis, if the cause is corrected, then the survival will be for 12 to 20 years. The survival will be up to 12 to 20 years. If the decompensated, we try to intervene, the survival will be for 2 years. What are the common causes of cirrhosis? Common causes of cirrhosis: alcohol, viral hepatitis, biliary cirrhosis. These are the three main common causes of cirrhosis: alcohol, viral hepatitis, biliary cirrhosis. Other causes are non-alcoholic fatty liver disease, autoimmune hepatitis, inherited disorders like hereditary hemochromatosis or Wilson's disease, cryptogenic liver cirrhosis. Okay. Now complications. Let's study complications. First, study portal hypertension. Let's enumerate first. Portal hypertension, 3 problems straight because of portal hypertension: variceal bleed, ascites, spontaneous bacterial peritonitis, splenomegaly, leading to hypersplenism. Okay. Portal hypertension, variceal, ascites, SBP, spontaneous bacterial peritonitis, splenomegaly, leading to hypersplenism. Hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, other malnutrition, malabsorption, bone disease like osteomalacia, osteoporosis, blood abnormalities like anemia, leukopenia, thrombocytopenia, one of the earliest markers of liver cirrhosis, but asymptomatic, coagulopathy. So complications are portal hypertension, hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome. Others are malnutrition, malabsorption, bone disease, osteomalacia, osteoporosis, blood abnormalities, anemia, leukopenia, thrombocytopenia. Thrombocytopenia is one of the earliest markers of liver cirrhosis, but are asymptomatic, coagulopathy. Now portal hypertension. Now here is a diagram. Let's study this diagram first. This is liver. We can understand. This is portal vein. This is inferior vena cava. This is connected by hepatic vein. Liver is connected by hepatic vein to the inferior vena cava. Okay. Portal vein is getting its tributaries from superior mesenteric vein and the splenic vein. Splenic vein has has a tributary of inferior mesenteric vein. Okay, inferior mesenteric vein drains into splenic vein, superior mesenteric vein, and splenic vein drain into portal vein. Liver tissue has area of sinusoids, all function here. Okay. Now, splenic vein is all of these. Splenic vein, inferior mesenteric vein, superior mesenteric vein are taking circulation from esophagus, stomach, small, large intestine, toward third of rectum, upper, plus pancreas, spleen, gallbladder. Gut circulation, splanchnic circulation. Okay, gut circulation, splanchnic circulation, stomach, small intestine, toward third of rectum, upper, plus pancreas, spleen, gallbladder. Portal hypertension is an increase in the portal vein pressure and a back pressure into the portal vein. Portal hypertension is an increase in the portal vein pressure and a back pressure into the portal vein. But technically, definition, portal hypertension is measured by using hepatic venous pressure gradient, HVPG. Normally, HVPG is less than 5 mm of mercury. Portal hypertension diagnosed as HVPG more than 5 mm of mercury, but not done practically. If the HVPG, that is hepatic venous pressure gradient, is more than 5 mm of Hg, then we diagnose it as portal hypertension. If HVPG is more than 6 to 10 is then compensated cirrhosis. If HVPG is more than 12, decompensated, high risk of varicose bleeding. HVPG is more than 16, very poor prognosis. Actually, these should be equal to, and this should be more than 16. Okay, so HVPG more than 16, very poor prognosis. Okay. Drug-induced cirrhosis. There are some notes. Drug-induced cirrhosis not common, but hepatitis, yes, it's common. Drug-induced hepatitis is common. Decompensated patients can become asymptomatic, but it's for sure they can again become decompensated. So we give prophylaxis. If the speed of disease is very fast, patients can decompensate at lower pressure. That is, patients' clinical features depends on depends on various factors. They can be asymptomatic also. Ideally, since biopsy diagnosis, liver cirrhosis is a biopsy diagnosis, don't use cirrhosis term. Note, the patient can come to you because of, say, NFLD, viral hepatitis, alcohol, and you just see liver status. There is no order in the portal hypertension patients. Patients can come anyhow with any complication. We need to screen compensated patients. There is no time frame compensated when patient may go into decompensated. Difference between incidental finding and screening finding. Incidental finding, I was searching for something else, but I found this. Screening is, I was suspecting there is this, and I did a test, and test came out to be positive. This is screening. Most often patients come to us with a cause. We do a test. We diagnose as cirrhosis, but patient is asymptomatic for cirrhosis, so they is decompensated. Note, in real world, portal hypertension also is not a diagnosis of investigation, but diagnosed on the basis of its complications. Varices. Varices are present in up to 1/3 of patients who have liver cirrhosis. 10-15% patients who did not have varices, but cirrhosis will have varices. See, now let us study the varices. Complication of portal hypertension. We are studying portal hypertension. Now, portal hypertension can cause varices. Varices are present in up to 1/3 of patients who have liver cirrhosis. 10-15% patients who did not have varices, but cirrhosis will have varices. 1/3 of varices will bleed and can lead to death. So, see, 1/3 of liver cirrhosis patients will have varices. Out of those 1/3 will bleed. That can lead to death likely. These varices are occurring because of an increased backward pressure into the portal venous system, and this back pressure is causing varices. This back pressure is causing varices into the esophagus. These varices are dilated tortuous veins. Most varices are present in lower esophagus. Some varices are gastric varices. Think of both in India. Most varices are present in, where are they present? They are present in lower esophagus. Some varices are gastric varices. Think of both gastric varices and lower esophagus varices in India. As the patient has increase in portal hypertension, these varices will enlarge, become tense, They will rupture leading to bleed. These varices will enlarge, become tense. They will rupture leading to bleed. This can lead to hematemesis, massive hematemesis. Most common 99% patient is massive hematemesis due to ruptured varices, due to portal hypertension. Now hematemesis is rest of the blood that has not come out as hematemesis will cause melena and result in black tarry stools. Sometimes, rarely, anemia can occur if small continuous bleed is present. Anemia can be present. This hematemesis is always massive, profusely massive. The risk is shock. The patient can go into shock, hypovolemia, spontaneous bacterial peritonitis. No, not spontaneous. Sorry for this. Systolic blood pressure will fall to less than 90 millimeter of mercury. So hypovolemia and shock, less than SBP less than 90 millimeter of mercury. So basically, it's a medical emergency. Now, what is important here? All patients of suspected or known cirrhosis should be screened for esophageal varices by upper GI endoscopy. If you have a patient of alcoholism, viral hepatitis, biliary cirrhosis or NFLD, do an endoscopy and find if it is cirrhosis or not. Do UGI endoscopy in this. The patients of alcoholism, viral hepatitis, biliary cirrhosis and NFLD, do an endoscopy, find if it is a cirrhosis or not. Do UGI endoscopy. Where do you think UGI endoscope will give you will be fruitful? Where? In the high risk signs, where size of varices, location of the varices, any red spots, cherry red spots, hemorrhagic spots on varices, red wale sign, any red spots, hemorrhagic spots on varices, red wale sign, bluish discoloration of wall, nipple sign. Varices are a direct marker of portal hypertension, and portal hypertension is a direct marker of cirrhosis. If the patient bleeds, a lot of blood is ingested and stays in the gut. Now this blood that is in the gut will generate nitrogenous waste. This nitrogenous waste is absorbed back, and in this patient's liver, 1/5 patients will have risk of developing hepatic encephalopathy because the liver itself is not functioning so well in these patients, and above that, due to the blood nitrogenous waste that is being absorbed, it is increasing the load and it's going directly to the brain and causing hepatic encephalopathy. What's the management? Let's first discuss the compensated cirrhosis, which means the patient has never bled. Now, compensated patient, portal hypertension with varices, and now he is compensated, means he has never bled, he has no symptoms. You do a screening first. Do a screening upper GI endoscopy. Drug of choice is non-selective beta blockers. Drug of choice is propranolol, 40 mg per day, can increase up to maximum 80 to 120 mg to bring down portal hypertension, beta blockers. Other drugs are nadolol, carvedilol. Utility, it decreases the risk of first bleed. It decreases the risk of first bleed. Contraindications are, look for them. Third is endoscopic variceal ligation. Depending on surgeon's decision, you do a endoscopic variceal ligation. You basically ligate the varices using endoscopy. Now consider a patient who has decompensated. Decompensated with patients with symptoms. That is, in a patient with varices, symptoms are bleeding. Patient has active variceal bleeding happening. First, stop acute bleeding. What will you do? You consider it an emergency. You do a CAB protocol, that is circulation, the circulation, that is the BP, the shock has to be managed. Fluid management, you give IV fluids. Pehle, you have to stop the bleeding, and even before stopping the bleeding, you have to set an IV line, give IV fluids and give blood transfusion if possible, as soon as possible. Now to stop the variceal bleeding, what will you do? You will take a Foley's catheter or a sense taken Blakemore tube. Sense taken Blakemore tube, nasogastric tube, but with bulbs. It's basically a nasogastric tube, like a Riles tube, and with bulbs inflated and after some time deflate since no necrosis to tamponade out the varices. Vasopressin analog. Vasopressin analog, terlipressin, mostly used. Now you can give some drugs also. Vasopressin analog, terlipressin, and somatostatin analog, octreotide. Somatostatin analog, octreotide causes vasoconstriction of splanchnic arteries. Terlipressin, what does terlipressin do? It causes vasoconstriction of splanchnic arteries. It's a vasopressin analog, terlipressin. Somatostatin analog, it's octreotide. It's older. Final therapy. What is the final therapy? Final therapy, because the Sangstoken Blakemore tube is not definite. Drugs will not completely stop the bleeding. Final therapy is upper GI endoscopy, but needs stabilization for the upper GI endoscopy. After a few hours, based on judgment of doctor, you can do a UGI endoscopy and stop the bleeding. Now, secondary prophylaxis. Patient has bled. Now what will you do? What will you give? Drug of choice now is non-selective beta blocker. When patient has improved from shock, and you keep doing UGI endoscopic screening. Okay, if the patient bleeds on beta blockers, it is a difficult patient to treat. Varices with portal hypertension with liver cirrhosis, treat the cause. And what else you can do? You can do a liver transplant. If you try to treat the cause and the cause is not being treated, then you can do a liver transplant. We actually go through, pierce the liver tissue and put a stent in portal vein. There is something called a TIPS, transjugular intrahepatic portosystemic shunt. TIPS. There is a technique, TIPS, transjugular intrahepatic portosystemic shunt, TIPS. Okay. If the patient rebleeds, you quickly do a TIPS. This procedure, this shunt you put and piercing the liver tissue, making a shunt between the portal vein and the inferior vena cava or hepatic vein that surpasses the liver. The blood now goes through the liver, but there is a stent, there is basically a pipe through the liver that lets the blood flow normally to the liver, not being cleaned, not being processed by the liver for toxins. Now, TIPS. So you are understanding this, that portal hypertension would be decreased because the liver is not putting back pressure on the portal vein, but also liver is not detoxifying the blood. Note, TIPS is an endovascular procedure. Its advantage, it's a fast procedure. It reduces the risk of rebleeding and other complications also. Problem is, toxin can reach the systemic circulation without detoxification. As a result, can develop hepatic encephalopathy. We avoid TIPS if patient has hepatic encephalopathy. Rather, we do liver transplant, but TIPS is a resolution in itself. Note for the doubts. If sense taken Blakemore tube, you are in no position to treat this patient. Refer this patient. You may also do urgent TIPS if circumstances are so. Rupture can occur while ligation and even during endoscopy. We have to inflate the esophagus by gas, so like 5% patients can bleed while doing the procedure. There is no alternative drug to beta blockers. Variceal bleeding painless. If pain, think of peptic ulcer. If there is pain during bleeding, think of peptic ulcer. Sclerotherapy was used in earlier times, not today. By the time patient has repeated bleeding, the patient also has other complications side by side. Ligated band will fall off after necrosis. Tips will fail after some months. It's just like borrowing time for before death. See, by the time patient has repeated bleeding, the patient also has other complications also side by side. Okay. This is one lecture of liver cirrhosis. Okay.